All right, afternoon, everybody. I hope everyone can hear us. So welcome to this week's Grand Round, out with the old, in with the new, the management of paracetamol overdose with the new SNAP regime at Imperial. My name is Sahil. I'm one of the emergency medicine trainees. This is Dr. Lucia Posani. We're a hepatology consultant, and we're both based at St. Mary's. So in today's session, we'll cover a few things. We'll briefly review the role of N-acetylcysteine or NAC in paracetamol overdose and some of its common side effects. We'll then go through some of the key research which has led to the development of SNAP and explain its rationale as a regime that now replaces the traditional 21-hour protocol. Look at its benefits, and hopefully I'll convince you of its superiority in clinical practice. We'll look at how effectively we've managed to implement SNAP thus far at the Trust, and we'll go through our new guideline to help you all safely treat patients using it. Look at how you should treat adverse reactions to NAC should they occur, how to differentiate between liver injury versus liver failure, and then end by thinking how to escalate patients who are unwell with toxicity and criteria for liver transplant. So paracetamol is the most common overdose that's taken in the UK, and accounts for about 50,000 hospital admissions and 150 deaths a year. So that is a significant number. And in terms of how paracetamol causes this injury, it's metabolized in the liver normally by the CYP450 system, generating this toxic chemical NAPQI that under normal circumstances would be detoxified by conjugation with glutathione and then excreted in the urine. But in paracetamol overdose, the liver's reserves of glutathione are depleted, and so this leaves the NAPQI free and able to cause liver cell damage and then ultimately liver failure. And in the same way, the CYP450 system is expressed in the kidney too, so free NAPQI can cause renal cell death and then ultimately renal failure too. But N-acetylcysteine or NAC is the antidote for paracetamol poisoning, as I'm sure many of you are already aware. And it has this beneficial effect by supplying cysteine, which is one of the 3 amino acids that glutathione is made up of, replenishing the liver stores and therefore preventing liver injury. And the value of NAC for this purpose was actually discovered in the 1970s in Edinburgh. And at that point, it was formulated into this 21-hour regimen as a way of at least starting antidote administration and getting effective concentrations into the bloodstream. And actually, since it was derived, the protocols remained largely unchanged. And it's still taught in medical schools and used as first-line treatment for paracetamol overdose across most NHS trusts. As I'm sure you're aware, it comprises a 3-bag regime over 21 hours, after which you repeat blood tests, and if set biochemical criteria aren't met, then you keep giving NAC with 16 hourly bags. And that's going to be in the circumstance of big overdoses where even many hours after drug ingestion, and despite the patient having the 21-hour regime, there's still paracetamol in their system, generating that toxic NAPQI, and so necessitating prolonged antidote administration. And there's also plenty of evidence that in big paracetamol-induced liver injuries, that ongoing NAC has an extra hepatic benefit to other organs and also improves survival rates. Now, amongst some other issues, the 21-hour NAC protocol causes anaphylactoid reactions in up to 20% of patients. These are non-IgE mediated hypersensitivity reactions, which commonly cause the symptoms that this young woman is displaying down here. And the most common of these would be nausea and vomiting. And of course, as well as being unpleasant for patients, these reactions often cause us as doctors to interrupt vital NAC treatment whilst we give antihistamines and antiemetics, and in the most extreme cases might even make us apprehensive to withhold or even not give NAC treatment on the basis that patients have been inappropriately labelled as having anaphylactic reactions previously, which no doubt affects patient safety and the outcomes of what is otherwise quite a high risk poisoning population. And identifying this as a problem, these reactions, really has made people think over the years about whether there's a better way for us to be giving NAC to our patients. And one of the things that was recognized is that the incidence of these reactions is well correlated to the rate of infusion of NAC and its serum concentration, particularly when it gets above 650 milligrams a litre in the patient's bloodstream. So typically these reactions occur during the high dose loading infusion of the regimen. And that's something you might have even noticed in your own practice, which is that patients begin to feel nauseous or vomit quite profusely within even the first hour of you giving them their NAC. And so this is
is it dangerous? Are any of those reactions actually dangerous, or is it just a perception?
So they're extremely unpleasant for patients, firstly, and then they can often manifest, like it says here, with hypertension and bronchospasm. So they're indifferentiable under those circumstances from anaphylaxis. And so they can result in circulatory collapse at that point, and they should be treated as anaphylaxis at that point too. And then the sequelae in the sense of being unpleasant, causing NAC interruption, and therefore maybe precipitating worsened liver injury. So yeah, they can be very dangerous from those two angles. Yeah. So this is where the SNAP regime really steps into gear then. So again, it was derived in Edinburgh, where Dr. Thanakudi's group were looking at serum NAC concentrations and how they fluctuated with different concentrations of infusion and rates of infusion. And from their pool of data, they suggested this new regime, which would give the same 300 milligram per kilogram as the 21-hour infusion, but would do so over a 12-hour period instead. So starting with a low dose infusion of 100 mg per kg over 2 hours, and then dose incrementing up to a 200 milligram per kilogram over 10 hours. Whilst the 21-hour regimen, you take the repeat blood test after the infusion is finished, and then you review the results to make a decision whether to restart NAC. In their suggested new protocol, they suggested taking blood tests 2 hours before the infusion finishes, and then reviewing the results to make a decision about stopping NAC. They then took their regime or their proposal and they plugged it into something called a Monte Carlo simulation, which is this diagram here, to try and generate some expected plasma concentrations using it. And what they found was that there was over a 99% probability that after the 2-hour loading infusion, the serum NAC concentration would be between 150 but critically less than that vital 650 milligram per litre mark. So essentially the theory is that SNAP would give 300 milligram per kilogram of NAC, just like 21-hour infusion, but it would generate a lower peak and a lower 20-hour plasma concentration, a smoother serum profile of NAC concentration, and kind of therein produce less anaphylactoid reaction, or at least that's the theory. But is that really obviously the case in clinical practice? So they took their regimen and they trialed it in a double-blind randomized study of over 200 selected patients from the Infirmary Edinburgh, the RVI Newcastle, and in St. Thomas's. And as this table shows, what they found was that if SNAP was followed exactly as they proposed, with repeat blood tests taken at the correct times and acted upon appropriately, then SNAP was as effective in preventing liver injury as the 21-hour regime. And critically, it generated a statistically significant reduction in anaphylactoid reaction, with the number needed to treat of just 10 to prevent one reaction. That's a pretty good going statistic. And then in the real world, as it were, they then trialed it in 3,000 plus unselected patients across the same hospitals and published in the Lancet, showing that yes, it was better tolerated by patients with less reactions. And as this plot shows, it has equivalence in terms of clinical efficacy compared to the 21-hour regime. So SNAP is kind of, in summary, safer for patients, simpler, it's as effective as 21-hour NAC, and it also gives big overdoses, more NAC within a 21-hour period compared to that old regime. We would emphasize that yes, while SNAP is shorter, but especially for low-risk overdoses, and that its main aim isn't to facilitate early discharge of patients. It really is about patient safety more than anything. That's probably just a secondary benefit. And in light of all of these positives, it's been first-line treatment actually for the management of paracetamol overdose since August of last year at Imperial. Having said that, we do need to improve our implementation of the regime locally. And this really came to light from an index case that occurred in November of last year. We thought it'd be quite interesting to go through that. So this was a young female that actually came to Mary's in November of last year with quite a significant overdose, as you can see, of paracetamol. And she was seen by A&E quite quickly and commenced on the on NAC via the SNAP regime. She did have a quite significant paracetamol level at 4 hours, over 300, a lactate of 2.3, but otherwise a stable or normal renal and liver function on presentation. She was admitted then under the medical team for further management. There was, however, no acknowledgement from either the clerking doctor or the post-take team that the patient was on the modified 12-hour regime or the tox base had been consulted. And so the plan from the post-take round was for the patient to have repeat blood tests taken after she finished the 12-hour NAC infusion, which, as we've seen from the Edinburgh group, it isn't the correct monitoring schedule she needed. Nonetheless, she had blood tests taken the next morning at 10 o'clock and reviewed in the afternoon. And this showed that her ALT had actually gone from normal to over 300. Her bili was raised and she still had paracetamol in her system. And the plan from the team was to repeat her blood test in 24 hours time. And despite her having an indication at this time for more NAC, she wasn't actually given any. And again, there's no documentation that the space had been referred to. Later on that evening, she was seen by the on-call team because of abdominal pain and vomiting. This was attributed to constipation. She was given some laxatives. And then the next morning, as planned, she had repeat blood tests taken. And again, these were seen only in the afternoon, by which point her liver dysfunction had become further established. So she had an INR of now 2, her ALT and bili had continued to increase. And after consultation with the Royal Free, she was commenced on back-to-back NAC at 4 o'clock that afternoon. So in total, this patient had a 30-hour delay in getting the NAC that actually she needed the day previously. Later on that evening, her liver derangement actually hit its peak. Her INR went to 4.6, ALT continued to climb, and her creatinine was now also creeping up. And by the next morning, even though her liver function was responding to continual NAC, her AKI was worsening. And that actually rapidly progressed over the next few days to the point on day 8 that she was oliguric and fluid overloaded and needed transfer to Hammersmith for renal replacement therapy. And she stayed 8 days there getting dialyzed until day 19 when she was fit for discharge, at which point her synthetic function had restored. And her creatinine was downtrending. But quite clearly, this young patient had quite a difficult admission. And one of the main reflections that we took from the case was a lack of familiarity of SNAP amongst our medical teams and an unawareness of the blood test monitoring required to make sure that she actually got a vital treatment early on. And following on from that index case, we did an audit of practice looking at all the patients, both at Mary's and at Charing Cross, who got NAC via SNAP between October and November last year. And we found that actually 13 of the 14 patients who were on the regime didn't have blood tests taken at the appropriate times or actioned to ensure that we were safely using this new regime. We also found that all 4 of the high-risk patients, as you can see in this table, who needed ongoing NAC after the 12-hour infusion had avoidable treatment delays in it being given, so kind of between 5 and 30 hours delay. And the last thing that came to attention was that actually the current tox-based guidance does not match the protocol formulated by the Edinburgh group, so kind of set up for a risk of misimplementation throughout. And with that all in mind, We've now created our own local guideline for SNAP at Imperia, which you can find by searching the internet for SNAP, and it comprises this flowchart plus a full text guideline as well. And kind of as informed by the results of our audit, one of the main priorities of this guideline is to make clear that unlike 21-hour NAC, where you take blood tests after the infusion's ended, and then you wait for the results before making a decision to restart NAC. In the new regime, you take blood tests 2 hours before a bag finishes. You continue to give NAC whilst waiting for the results, even if this means starting a new bag. And then when you've got the results back, that allows you to make a decision to stop NAC. You'll see as we go through this that whenever the current treatment bag is running, you should make sure the next one is prescribed. And if you're ever in doubt, the safest thing to do is to continue giving NAC at the same rate of dose of the last bag and seek some senior advice. Importantly, in practical terms, for a patient who comes to us with a paracetamol overdose, you should still use Toxbase to decide whether that patient qualifies for NAC treatment or not. And once they do, this guideline becomes your first port of call. We thought we kind of go through it. It is very simple to use. So for a patient who presents with overdose, you simply start at the top box. Most commonly, you'll be ED-seeing these patients first, who commence them on the NAC via SNAP using the care set on the orders tab of Cerner. And when the patient comes into acute medicine, the clerking doctor should go back into that care set and ensure that a third bag of NAC is prescribed, just in case ongoing infusion is needed. 2 hours before the second bag of NAC finishes, you check their ALT, their INR, their paracetamol. And because of the time required in the lab for those samples to be processed, it is unlikely you'll get them back before that second bag of NAC finishes. So you should just proceed to give the third bag while you wait for the results. And it's important that we let our nursing staff know just to continue NAC administration. When you do have the results, you compare them to the criteria in this first box on the right. If the criteria met, you can simply stop NAC and repeat the ALT and the INR 8 hours later. And again, if criteria met, then your patient's fit for discharge. And within that 8-hour period, if they need psych evaluation, that can be done at that point. Of course, if the criteria in these two boxes aren't met, then the patient does need ongoing NAC. So if you've got a third bag running, you simply continue it. If not, you start one, prescribe the fourth. As before, repeat the blood test 2 hours before the third bag of NAC finishes. Continue with the fourth bag whilst you wait for the results and assess according to criteria. Simply, if the criteria met, you can stop NAC, or if not, you'll need to keep giving NAC as back-to-back bags until their INR until the INR normalizes, as it says on the bottom. And we hope that if you're getting to the third or the fourth bag of NAC, definitely the Mary's hepatology registrar should really be aware, if not already involved with this patient's care. So as I said, in summary, we want to urge you to know that this current guideline and this monitoring schedule is different from what you'll see on Toxbase when you look under the SNAP section. And so it's important that we're using this when we're managing these patients locally on the SNAP regime. If a reaction does take place, if the patient isn't stable, as we've already mentioned with Dr. Miran's question, you will be unable to distinguish anaphylactoid reaction from anaphylaxis. So it's important to just proceed to treat it as anaphylaxis. But in the majority of cases, this won't be the case. The patient will most likely just be nauseous or vomiting quite significantly. So at that point, you can pause NAC, give some fluids, some intravenous chlorphenamine, maybe some nebs if they're a little bit wheezy. And once their symptoms have settled, you are safe to restart NAC, just kind of half the rate for the next 4 hours, and then return to the original rate. Be mindful, obviously, that that particular bag will become prolonged. So you'll need to just adjust when you take repeat blood tests, still doing it 2 hours before. And we'd emphasize that you need to document very clearly in the notes what the features of the reaction were, for kind of our audit purposes as well. I'm just going to hand over to Dr. Pasani.
Thank you. So for the next 5 to 10 minutes, I just wanted to take the chance just to talk through that recognition of the more severe cases about appropriate referral and monitoring of patients who are developing organ dysfunction. I think paracetamol overdose, 100,000 people present to A&E each year with paracetamol overdose. About half of those are admitted to acute medicine for N-acetylcysteine treatment. So this is really common, and we see a lot of mild cases, but only about 100 to 200 deaths occur each year, and only about 20 to 40 liver transplants are performed for this indication. So I think that maths makes it quite a difficult case, a difficult condition to treat, in that our perceived perception of risk is often reduced by the fact that it's quite a common presentation and generally relatively mild. And I think in the case that Sahil has presented, where that patient on the post-take ward round was put down for 24-hour bloods, which were then reviewed the next afternoon, obviously indicated that there wasn't that perception that that patient was at risk of severe outcomes, and possibly led to some preventable delays in their treatment. And so I just want to take you through really this kind of pyramids that I've done of the severity of paracetamol overdose. And a lot of patients who take an overdose won't even develop any liver dysfunction at all with a normal ALT. And then you'll see a proportion of patients who will develop what we call an acute liver injury in terms of having an elevation in their ALT or AST, but without synthetic dysfunction. And by synthetic dysfunction, I mean an absence of coagulopathy, so a normal prothrombin time, and an absence of jaundice, a normal bilirubin. And it's particularly the coagulopathy that develops earliest in paracetamol overdose. And then there are patients, the next level of severity is an acute liver injury with synthetic dysfunction, and that's when you start to see prolongation of the prothrombin time or an elevation of the bilirubin. And then the next step, which is really critical, and I'll take a bit more time, is the development of acute liver failure, and this recognition of the difference between a severe acute liver injury and acute liver failure is very important. The ALT is often the most striking thing we notice when we look at the bloods in paracetamol overdose, and it does reflect the degree of hepatocyte injury, but importantly, it's very poor prognostic significance. So you'll notice that a lot of the prognostic criteria as we go through don't really rely on ALT particularly. So this distinction between acute liver injury and acute liver failure is important. Acute liver injury, as I've said, is actually quite a common clinical entity with an elevation acutely in the ALT or AST, and the severity of that liver injury is determined by the degree of synthetic impairment as evidenced by prothrombin time and jaundice. Acute liver failure is a very rare clinical condition and is characterised by this triad of jaundice, coagulopathy, with encephalopathy, and so it's the emergence of encephalopathy is the key defining feature of acute liver failure and distinguishes it from acute liver injury, and that needs to occur in a patient without pre-existing liver disease over a short time period. And so this figure taken from the European guidelines shows it's this key crucial development of hepatic encephalopathy that defines acute liver failure. And that can occur up to 12 weeks. Obviously, in paracetamol overdose, this tends to be a much shorter time frame. And in fact, sometimes paracetamol overdose is termed hyperacute or fulminant acute liver failure, with the recognition that progression from jaundice to the development of encephalopathy occurs over just a few days and certainly within a week. And that means it behaves slightly differently as a clinical entity to the more indolent forms or acute or subacute liver failure. It tends to have a much more pronounced prolongation of the prothrombin time, less pronounced jaundice, and the intracranial hypertension and hepatic encephalopathy and hepatic coma can be more pronounced. And almost paradoxically, however, it does have a better chance of spontaneous recovery. So just because encephalopathy is this really key feature of recognising acute liver failure, and that has massive prognostic significance, I just wanted to talk briefly about some kind of tips and things for clinical practice when you're assessing patients. Encephalopathy and acute liver failure is graded by the same criteria we grade encephalopathy in cirrhotic patients. So the West Haven criteria, which grade the degree of encephalopathy from 1 to 4, with 1 being quite subtle cognitive defects and 4 through to 4 being coma. And that progression can be very rapid in acute liver failure over hours, and grades 3 to 4 require airway support, which just emphasises the importance of careful monitoring. In acute liver failure, the encephalopathy reflects not just the accumulation of ammonia due to the failing liver, but also the systemic inflammatory response. It leads to quite pronounced cerebral edema, and if left untreated, can lead to coning and death. Identifying the kind of lower grades of hepatic encephalopathy, therefore, and acting on them quickly is important. And in terms of the clinical assessment, I would look for initially when you're reviewing patients, mental slowing, difficulty recalling facts for history, and mood disturbance, which I appreciate can be quite difficult, particularly with patients presenting with overdose, sometimes mixed drug overdose or alcohol, and often with psychiatric histories. A nice bedside test I like to apply for hepatic encephalopathy is this animal naming in 1 minute, where you ask a patient to name as many different animals as they can in 1 minute. And if they get under 10, that does suggest a significant degree of mental slowing. Between 10 and 15 is kind of borderline, and over 15 normally suggests they've got quite good recall, and it's something that can be applied and quantified quite easily. Asterixis is obviously quite a good hard clinical finding, tends only to occur in grade 2 or above, although it does vary from patient to patient, so definitely worth checking for. And documentation of GCS in the presence or absence of hyperreflexia and clonus if you're assessing patients. You may also be asked to provide an arterial ammonia if you're speaking to a transplant centre, as it has important prognostic significance in encephalopathy, and arterial ammonia is above about 120 are an indication for filtration in these patients. So in terms of who you should be escalating, I've taken this box on the left from the guideline that Sahil's just presented to you, and our team at St Mary's, who can be reached on the hepatology registrar bleep 31613, would really like to see those patients with the acute liver injury with synthetic dysfunction, so that kind of box in the pyramid where they're starting to develop a coagulopathy, and I would classify that as anything with an INR over 1.5 to be aware of and start to be involved in their care. Obviously, I've also put the metabolic factors of lactate, pH, AKI, and encephalopathy in that box, which are possibly more severe. But anyone with synthetic dysfunction, we would like to know about them and start to be involved. And then these are national, actually in the EASL, the European guidelines now, these can suggest the criteria for referral to a specialist unit. And by that we mean our regional transplant centre, who is royal free. And these can easily be found through a Google search, so not expecting people to memorise them, but just know that there are defined criteria for referral to specialist centres, which you'll notice don't include the ALT, as I've mentioned, but do include metabolic status, coagulopathy, presence of encephalopathy, and renal dysfunction. And then just again, these are just really to be aware that these are the listing criteria for super urgent transplant for acute liver failure due to paracetamol. Just to be aware that they exist, and again based on mainly metabolic factors of a persisting acidosis or high lactate after resuscitation, so after more than 24 hours since ingestion despite fluid resuscitation, or the presence of all three of these three criteria of high-grade hepatic encephalopathy, renal dysfunction, and a severe coagulopathy. And certainly, so just to kind of get your eye in as to what factors are important for prognosis and onward referral. And so kind of putting this together with our pyramid earlier, so in terms of escalation, obviously most of these patients are managed in A&E and acute medicine, and I'd please encourage you to try to use the guidelines that we've just described. Those patients who are developing synthetic dysfunction, would be great if you could refer them for local hepatology input. And then obviously we'd like to be involved, and if there's evidence of developing encephalopathy or some of those criteria being met, we would be speaking to the Royal Free and getting their input, and also speaking to our critical care colleagues. And obviously once acute liver failure is developing, we need to have a very rapid conversation, make a decision about whether transplant assessment and transfer to regional transplant centres is appropriate. And although I've obviously encouraged to refer through us, do beware, obviously, the case of the delayed presentation of a concealed overdose or a patient presenting in the middle of the night with established acute liver failure to A&E, then the appropriate thing to do at that stage would obviously be to go direct to the Royal Free and the regional transplant centres. They don't delay that referral. And so how you know that where the patient is on this pyramid is all about monitoring, which is why check bloods in 24 hours and review them in a further 8 hours, is what we should be doing for these patients. You need to know whether the synthetic functions are going off. You need to know whether there's developing hepatic encephalopathy, and you need to have a good grasp of what their metabolic status is. So regular checking of BBG, NFTs, clotting, renal function, glucose, and assessment for the development of encephalopathy are important, and you may be asked to do an arterial ammonia, that I wouldn't recommend on every paracetamol overdose, but that would be the case. So the take-home messages from today is that paracetamol overdose is a common presentation, and although the vast majority can be safely discharged, careful monitoring is required. There are new trust guidelines using the new SNAP regimen, which has a real benefit in terms of reducing anaphylactoid reactions. They can be found on the internet. That flowchart hopefully is really going to be helpful in terms of guiding your monitoring decisions and choosing which patients need prolonged NAC, and also giving you safe thresholds for discharge and providing reassurance that you can discharge patients safely. I'd encourage you please to refer patients who have synthetic dysfunction with their acute liver injury to us at Hepatology, and just be aware that you can find criteria for transplant referral or liver transplant listing online if you need them in the middle of the night. Thank you very much for your time and attention.
Gosh, thank you very much. That's game changing for me, because I was unaware of the SNAP guidelines, I'm ashamed to say. And, you know, because we've all been taught these guidelines from the distant past. And it needs to be really well known, which is why I'm doing this today. I'm aware of that. What else? How else can we make sure that we all know about it? Because, of course, what one would get confused about on a post-op ward round, I would have until today, was mixing the two protocols up. And then the second thing is, could you not make your care set include the third bag?
Yes, that's a very good point, and we have spoken to pharmacy about that. The issue with including the third bag is that our Cerner care sets are shared with Chelsea and Westminster, who have not necessarily agreed yet to that third bag, but we are going to try and work on the whole care set, so the third bag is automatically prescribed, and therefore there has to be a conscious decision to stop NAC rather than what happens at the moment. What we found in the audit was that people just kind of fell off the end of the prescription, and then it never really got restarted until there was a conscious decision to restart.
Yes, because when you started that, it looked like it was only 2 bags, that presentation. I thought that looks quite good, 12 hours worth. So that's a misunderstanding, isn't it, really? It's 3 bags minus 1 if you're doing well.
Yeah, I think if you get the blood results in time, you can achieve 2 bags, and I think the results of our audit really pushed us to be as cautious as possible and get that third bag prescribed automatically. I think half an hour and a half delay in restarting it probably wouldn't be critical, but it's the fact that if it's not there and it doesn't get spotted till the next time someone does a ward round, then that's when you get the lengthy delay. So shifting this focus to a conscious decision to stop rather than having to think about restarting is what we thought was the safest practice.
I mean, can you think of a downside to doing the 3 bags? Chelsea is not going to think that's a bad idea. It's just someone needs to look at it, I think.
Yes, I think they would. Yeah, we will go back to them. We've had some discussion about whether to start again, and we'll go back to pharmacy and see if we can get that through.
There's a question on the chat from Trish Ward. Thanks for the excellent talk. Do you have any further advice about managing staggered paracetamol overdose? Presume indicating to a NAC and SNAP regimen unaltered from previous guidance. Yes,
staggered paracetamol overdoses are higher risk by definition, and there's specific criteria on when to start N-acetylcysteine, and obviously at much lower thresholds than with a single point of time entry. Once they're on to the SNAP, it's the same monitoring blood test that you would do for a standard or a single point time point paracetamol overdose. So again, follow the flow chart and you'll be safe.
And there's another question on the chat about whether, if you have significantly abnormal blood tests, whether you need to go back to the old regimen. In other words, does the new SNAP guidelines only apply to good blood tests?
No, it's for all. And actually, if the blood tests are bad and therefore you have to continue the NAC, they end up getting more N-acetylcysteine on the SNAP regimen over the first period than they would have in the old one. So this is a milder regimen. And it's equally efficacious and actually delivers more N-acetylcysteine as long as you're following the flow charts and not leaving significant treatment delays.
Okay, there's another one here. Okay, yes, it is very useful. Thank you very much. Any other questions, anybody? Because if we look this up guideline wise, when we're busy, might we find the old guidelines?
Not if you look on the intranet.
Excellent. Okay.
There was no guideline before. That's
And then there's a hand up from George.
Just a quick question. So when we've had overdoses and the liver functions going off over the weekend, we were never sure whether we should call the raw free or king. So it just depends, luckily, who we get through. And often in the times I've had this, they've always asked me to do a triple phase CT abdominal scan. And I wasn't entirely sure the purpose of that, nor was radiology. And I was wondering if you could clarify that to me too, please.
On the first point, the royal free should be the first people you pick up the phone to, just with an established relationship between us and they're our local unit, and we refer our transplants to them. Obviously, if there was a particular reason that you just couldn't get through and you needed an urgent opinion, I don't think anyone would criticise picking up the phone to Kings and speaking to them, but it is the royal free. On the second point, although those criteria for listing for super urgent liver transplant are quite clear and don't involve a triple phase CT, you obviously need to also screen for other things, portal vein thrombosis, disseminated malignancy and things before anyone would ever make it onto a liver transplant super urgent list. So I think it's just getting those investigations early and checking that there's nothing else critical going on in the abdomen. And that would be my response to radiology at the weekend.
And there's a question about arterial versus venous ammonia. Is there any reason why we can't do venous ammonia?
There is a difference, and venous ammonia is obviously subject to tissue kind of perfusion factors, and so the thresholds that they tend to look at are arterial. And you will probably be asked for an arterial one if you do call up a transplant unit. Tends to be about 20 to 40 lower arterially. Yeah.
Any other questions? I don't think it's often that we have a talk which changes practice. So this is then make sure that we all know about this practice, because you have randomized controlled trials, but until it gets into the guidelines, we get stuck, don't we? So this is really good. Thank you very much indeed for informing me anyway. I don't know if everybody else knew about it, but clearly, George, I need a bit more acute medicine, don't I?
Yeah, I was going to say it's a really good talk, because obviously it's highlighting, I would say, established practice now, hopefully. But I have emailed all the consultants the guidance this morning, and we're recording this talk so we can transmit it, hopefully, to everyone else who unfortunately couldn't come today. So thank you so much for bringing up that case. It's really good.
You're very welcome. Thank you very much.
Thank you.